Mhm.
Good afternoon, everyone, and good evening to some of you. Welcome to day 3 of Zero's Prostate Cancer Summit. I'm Shelby Monier, Vice President of Zero's Patient Programs and Education. Before we jump in, I'd like to take a quick moment to thank our sponsor, Janssen, for helping us bring this really great content to you. Now, joining me today is Chelsie Ferrell, who is a physician assistant at Advanced Urology Institute, and she specializes in advanced prostate cancer. So, Chelsie, I'll let you take it away and introduce your talk and yourself.
Thank you, Shelby. I really appreciate it. I want to thank everybody for having me. I really look forward to teaching everybody about prostate cancer, specifically advanced prostate cancer. I've been working with advanced prostate cancer patients for about 7 years, so it's really exciting to be able to have a forum to be able to talk and educate prostate cancer patients on all ends of the spectrum. So without further ado, I think we can go ahead and get started if that's okay.
Yeah, absolutely. Thanks for being here.
All right, thank you. Okay, so what we're going to talk about today is we're going to talk about prostate cancer. Specifically, we're going to be talking about patients who have advanced prostate cancer, but we're going to kind of discuss the entire disease continuum. So without further ado, we'll go ahead and get started. Oops, sorry, somehow we flipped to the middle, of course. Sorry, guys. Giving you just a sneak peek of what we've got coming. All right, so these are our learning objectives. So first we're going to start with an overview of prostate cancer. Specifically, we're going to talk about how prostate cancer progresses from localized disease all the way to metastatic disease. And then we're going to talk about these two areas of prostate cancer called non-metastatic castrate-resistant prostate cancer, as well as metastatic castrate-sensitive prostate cancer. And that sounds like a mouthful now, but by the time everything is said and done, you'll all be professionals. And then we're going to talk about potential treatment options. So the day that a man is diagnosed with prostate cancer, regardless of the stage or grade or where they're at in their disease, it changes the life of the patient and the patient's family for that matter. And research shows that men typically deal with this in one of 4 different ways. So some men may take a proactive approach. They, fight or flight kicks in and they kind of decide to go at things swinging. Some men take more of a practical approach. I find that oftentimes these men are maybe a little bit less emotional about it. They may be a little bit more stoic. And oftentimes these people are goal oriented. Oftentimes these are people who come to the practice and they've done their own research. They may have ideas on different things that can be done to help in their disease. A lot of times men may feel confused. They may be embarrassed to ask questions because they just don't really know where to go from here. Oftentimes these patients rely on their provider to kind of, guide them through the process. And I find that some men may feel hopeless. They've just been given this diagnosis. They feel that they don't really have an option. And so they just kind of follow along. And oftentimes I find that this comes from a lack of understanding of what the treatment options are. They just feel overwhelmed, they feel confused, they don't know where to start. And that's why I think conferences and educational forums like this are so important. So that way men and families have an opportunity to learn about their prostate cancer. So when we talk about these emotions of confusion and hopelessness, again, like I had mentioned before, I think oftentimes that comes from a lack of understanding. And there's 3 main areas that research shows that men don't understand their prostate cancer well. And the first is the stages and how treatments differ within each of those stages. Do they have localized disease that maybe will just respond well to maybe watching their cancer? Are they still candidates for curative therapies like radiation therapy or removal of their prostate cancer? And then that kind of leads into the next thing is how prostate cancer progresses is another area of confusion. When they go from localized cancer to maybe cancer that is no longer responding to treatments anymore, and then on to metastatic disease, which is our third area of area where patients may tend to have a difficult time understanding, which is what does it mean to have metastatic cancer, and what does that mean for the progression of their cancer? And we're going to address all of these things in this presentation. And all of these things are really important because prostate cancer is the most commonly diagnosed cancer in men. And it's the second leading cause of cancer deaths. 10% of men who are diagnosed with prostate cancer will actually die of their disease, which is 1 man in 41 will die from prostate cancer. So while we do know that a lot of prostate cancers can be watched and followed, it's not a benign cancer. You know, there are more aggressive types, and we need to know how to treat these patients and how to act early to give them the best chance of survival and the longest life possible. So before we jump into Erleada, which is the topic of discussion today, what I'd like to do is just kind of talk about prostate cancer and how prostate cancer progresses from curative localized cancer all the way to what we call metastatic castrate-resistant prostate cancer. So you'll have a good understanding. We're going to spend a little bit of time on this slide, but it's really kind of the cornerstone at what helps us what will help you understand everything for this presentation. So when the majority of men come to a urology provider and they're diagnosed with prostate cancer, the hope is that they have localized disease. Localized disease means that the prostate cancer is still confined to the prostate. It hasn't spread to any other areas of the body. And when a patient has localized disease, of course, our goal is always to cure them. And we can do that by, well, there's a bunch of different treatment options, but the most common ones that we talk about are prostatectomy or removal of the prostate or radiation therapy. Unfortunately, about 20 to 30% of men will fail that treatment. And when they do, they develop biochemical recurrence, meaning their PSA starts to rise. And when that happens, we have to get a little bit more creative in the way that we treat the prostate cancer. And we do that by taking away the food of prostate cancer, which is testosterone. So previously, we used to treat this with surgical castration, which is removal of the testicles. So the testicles is the main source of testosterone production. So before we had, treatment options available, the treatment of choice was surgical castration or removal of both of the testicles, which is also called a bilateral orchiectomy. That would bring the testosterone down near zero and the PSA would follow. Now we have a little bit more of an elegant approach, and we use androgen deprivation therapy. And you may have heard of some of these treatments, such as Eligard, Lupron, Firmagon, and there's even a new one on the market called Orgovix, which is an oral medication. But basically, all of these medications bring the testosterone down near zero, and the PSA follows. Eventually, a patient may progress. And when they progress, we're down at this purple box down here, their PSA starts rising. So their testosterone is low, but they have a rising PSA. So that is the definition of castrate-resistant prostate cancer. They have prostate cancer that is resistant to those castrate levels of testosterone. And if the cancer has not metastasized or moved outside of the prostate, that is the definition of non-metastatic non-metastatic castrate-resistant prostate cancer. And if the patient progresses past this, meaning their PSA starts rising again and the cancer spreads, then they progress to what's called metastatic castrate-resistant prostate cancer, which is this bubble over here. They have prostate cancer that is resistant to those castrate levels of testosterone, and their cancer has spread. So let's talk about this bubble up here, metastatic castrate-sensitive prostate cancer. So unfortunately, there are some men who come to see us who are already metastatic at the time of diagnosis. They've never been treated before, and I find most often I meet these patients in the hospital. Maybe they haven't been seen by a primary doctor, they haven't had care before, and they come in and they find out when they're in the hospital that they have prostate cancer because we find it in their bones or their lymph nodes or other parts of their body. So they have never been on hormone treatment before. So they have prostate cancer that would be sensitive to those castrate levels of testosterone, meaning if we brought their testosterone down, the PSA would follow, but they already have metastatic disease. So metastatic castrate-sensitive prostate cancer. And if their cancer progresses from there, typically what we would do, we would put them on hormones, their PSA would decrease, but eventually that may fail. And when it does, they develop castrate-resistant prostate cancer, meaning their PSA is resistant to those castrate levels of testosterone, and they already have metastatic disease. So they are also over here in this bubble of metastatic castrate-resistant prostate cancer. And these three bubbles right here, metastatic castrate-sensitive prostate cancer, non-metastatic castrate-resistant prostate cancer, and metastatic castrate-resistant prostate cancer are what I would consider advanced prostate cancer, which, as I had mentioned before, is kind of where I specialize. So I briefly touched on this concept of metastasis. So metastasis means when cancer spreads outside of the place where it had initially formed. And different types of cancers metastasize to different parts of the body. So if we're talking about prostate cancer specifically, prostate cancer spreads most often to the bones. That's the main area that we see prostate cancer progress most commonly. It also goes to the lymph nodes, and then we will also see it go in later stages to what we call the visceral organs, meaning the solid organs in our body. And the most common ones in prostate cancer are the liver, the lungs, and the brain. Okay, so next we're going to talk about Erleada. So Erleada is a great medication that can be used in 2 out of the 3 advanced prostate cancer spaces that we had talked about previously. So the 2 indications for Erleada are non-metastatic castrate-resistant prostate cancer, meaning the prostate cancer that has not spread outside of the prostate, but is no longer responding to those lower levels of testosterone. And also for metastatic hormone sensitive or castrate sensitive prostate cancer, meaning the prostate cancer that will respond to low levels of testosterone, but unfortunately it has already metastasized. And we're going to go back to that visual on the next slide right here. So these 2 bubbles, metastatic castrate sensitive prostate cancer and non-metastatic castrate-resistant prostate cancer, are the 2 areas where we can use Erleada. And you can see here that the goal of placing a patient on Erleada in this time is to prevent progression to this space over here, which is metastatic castrate-resistant prostate cancer. So what we're going to do is we're going to start our discussion talking about metastatic castrate-sensitive prostate cancer, so the top bubble. And again, these are the patients that I had mentioned, typically have not been treated for their prostate cancer before, but unfortunately they're already metastatic at the time of diagnosis. So oftentimes these patients ask me, Chelsie, if you can put me on a medication like on androgen deprivation therapy, and that's going to bring my PSA down, why do I need to be on an additional medication on top of that? And the answer is because when you already have metastatic disease, unfortunately, those hormones are only going to work for a period of time. Eventually, those hormones will fail. And what Erleada does is it prolongs the amount of time that those hormones work until the cancer progresses to this metastatic castrate-resistant prostate cancer space. And we're going to hop into some of the data here. So in the studies, and again, this is patients who have metastatic castrate-sensitive prostate cancer. When patients were on Erleada in combination with ADT hormone treatment, there was a 33% reduction in the risk of death, as opposed to if they were on hormone therapy alone. And in addition to that, there was a 52% reduction in the risk of progression on their scans, as opposed to if they were on hormone therapy alone. Basically, what that means is we already know that they have metastatic disease at the time of diagnosis. But by adding Erleada, it reduces the amount of time until their metastasis or prostate cancer progresses past that and gets worse on their scans, both like a bone scan or a CAT scan. And there is actually a 61% reduction in the need for chemotherapy in patients who are receiving Erleada in combination with hormone therapy as opposed to hormone therapy by itself. Okay, so next we're going to shift our focus to patients who have non-metastatic castrate-resistant prostate cancer. And this is oftentimes a scary time for patients. So if you can imagine, most of these patients have been on hormone therapy alone for a while, right? They have developed this biochemical recurrence back here. Their PSA already started rising. We put them on hormone therapy. Their PSA has probably been low for a little while and they've been coasting along and doing well. And now all of a sudden their PSA is rising, even though their testosterone is low. So this is, again, a very scary time for people because, what they've been doing, what's been working is no longer working. And they know that if something isn't done, then they're going to progress to, their cancer spreading. So what we're trying to do is we're trying to prevent that progression to metastasis or spreading of prostate cancer. And this is another great reason to add Erleada in. And here is the data for that. So patients who were on Erleada plus hormone therapy who had PSAs that were starting to rise, they were able to go 40.5 months in comparison to patients who were on hormone therapy alone were only able to go 16.2 months until their prostate cancer spread to other areas of the body. So what that means is that when you start seeing the PSA going up, even though those testosterone levels are very low, if you start Erleada, you can buy an extra 2 years until the prostate cancer spreads. That's a really long time. And in addition to that, it helps patients live longer too. Patients who were started on Erleada early, who were found to have those rising PSAs, on average lived 14 months longer in comparison to those who were only on hormone therapy by itself. And there was also a decrease in the need for chemotherapy by 37% as well. Okay, so next we're going to talk about the precautions and potential side effects of Erleada. So we're going to start by talking about heart disease, stroke, or mini stroke. So there are some what we call cardiovascular adverse effects associated with Erleada. And part of that has to do with the fact that, the patients who are being treated with this population are already at a risk based on their gender, being male, and their age. Most of them are over 65. In addition to that, being on hormone therapy, like, androgen deprivation therapy, that can increase the risk for cardiovascular disease as well. And then being on Erleada and other medications like Erleada can increase that risk also. So it is very important to talk to your provider about your cardiac history. If you have a cardiac history, if you have a history of heart attacks, strokes, maybe congestive heart failures or arrhythmias. I can say that in my practice, every time I start a patient on a new medication, we talk about their heart disease, and I follow them every 6 months or so with a lipid panel just to make sure that, they're staying stable and healthy and everything, to keep them on track is being done. But again, you should talk to your provider if you're having any sort of symptoms, such as chest pain or shortness of breath, or symptoms of stroke, which are weakness, difficulty breathing, loss of balance, these types of things. Falls and fractures. So again, this patient population already by itself may be at a higher risk for falls and fractures because some patients who, need these medications may be older and frail. And in addition to that, being on hormone therapy alone weakens the bone structure. So it is very important for you as the patient or you as the family member to have a discussion with your provider before starting any medications about if it can cause fatigue or weakness, if it increases the risk of falls and fractures, about things that you can do to decrease those risks. things that I do in my practice is patients get DEXA scans, which is a scan to check the bone density to make sure their bone density is nice and healthy. There's medications that patients can be put on that help to increase their bone density. So these are all questions and discussions that you should be having with your provider to make sure that you're optimizing your care and getting everything that you need from your, from your treatment regimen. And seizures. There were a handful of patients between the two studies who did experience a seizure. A seizure history actually does not mean that you cannot take Erleada. It is not a contraindication, but it is very important to make sure that you have a discussion with your healthcare provider if you do have a history of seizures in the past. If you maybe are at an increased risk for seizures, such as a history of trauma or tumor or brain surgery. These are all things that you should talk to your healthcare provider about. And the most common adverse effects of Erleada are fatigue, falls and fractures. We did talk about that. Joint pain, rash. Rash is something that can happen with Erleada. It is not an allergy and oftentimes can be corrected, and it can be corrected and the medication can be restarted, and oftentimes it doesn't come back, but it is something that can happen. Decreased appetite, weight loss, hypertension, and hot flashes. Hot flashes are something that a lot of you may be familiar with because, again, that is something that happens on hormone therapy, such as androgen deprivation therapy. So again, being on Erleada can also exacerbate that some or make that worse. And diarrhea, sometimes that can happen. Most oftentimes, these are the most common side effects, but they're very mild in my experience. Rarely have I had to take a patient off of Erleada because of a side effect. And most of the time we can just reduce the dosage, and oftentimes that will do the trick. But again, you always want to have a discussion with your healthcare provider if you are experiencing a side effect, because most of the time there is something that can be done about that. Okay. So I know that we kind of already talked about androgens. Androgens meaning testosterone as being the food of prostate cancer, but this is a great little schematic that kind of helps us visualize things a little bit more. So before we get started, what I'd like to do is kind of talk about how prostate cancer grows. So you can see right here, this purple doodad here is our androgen receptor. So on the surface of every prostate cancer cell, there is what's called an androgen receptor. And what the androgen receptor does is it kind of sits outside of the prostate cancer cell and it waits for an androgen to come along. The most common androgen in prostate cancer is testosterone. We've talked about that in a lot of detail. So what happens is when that androgen receptor binds to the androgen or testosterone, it goes into the cell and everything that's needed for prostate cancer to grow takes place. The prostate cancer cell grows, divides, multiplies, and prostate cancer progresses. So when we give androgen deprivation therapy reduces the amount of circulating androgens or testosterone in the bloodstream. But, it's not perfect, right? Number one, there's no perfect medication. And number two, we actually get a little bit of extra testosterone produced from the adrenal gland. So even women have testosterone in some degree. So, that remaining testosterone is enough that it can interact with that androgen receptor and prostate cancer can proliferate and grow. So what Erleada does is what's called competitive binding. What it does is it takes the place of where the testosterone would bind. As a result, the testosterone can't bind, the prostate cancer receptor cannot go into the cell, and the cell does not provide, and that the cell does not divide or proliferate. And as a result, that kind of keeps the prostate cancer from growing. Okay, so, before you start a new medication, you should always talk to your provider about your other health conditions. So we've already kind of talked about a history of heart disease. So if you have any type of heart disease or, diseases that could lead to heart disease, such as cholesterol issues, high blood pressure, that's something that you want to talk to your healthcare provider about. Again, diabetes. So we don't really think about diabetes as going hand in hand with heart disease, but it does. One of the biggest things that diabetes affects is the blood vessels. So it's very important to have a discussion about your provider if you have diabetes. I personally check a blood glucose every 6 weeks to 3 months, depending on how often I'm following a patient, to make sure that their blood glucose is staying in check. A history of seizures or other neurologic brain conditions. So again, seizures, brain injury, stroke, tumors, these are all things that you need to talk to your healthcare provider about. Again, it doesn't mean that you can't be on the medication, but they should know about it before they are, before they're prescribing you a medication. And finally, if they have a partner of childbearing age, especially if they're planning pregnancy. This is for 2 reasons. Number one, this will cause infertility. Androgen deprivation therapy alone will probably cause infertility also, but if you are, unfortunately, we do have some men that are younger in their 50s and, they have partners of childbearing age and may want to get pregnant. So, it is something to talk about, because before we kind of get started on this, if that's something that's important, you may want to talk about maybe banking sperm or trying to get pregnant earlier. In addition to that, this has not been studied in pregnancy or lactation or anything like that. So if you have a partner of childbearing age, it's important to make sure that we're using contraception, because it hasn't been studied in that way, and it can cause harm to an unborn child. It's also important to talk to your healthcare provider about the medications you take. In my practice, I always like my patients to come with an active medication list. And I think it's even better if they come with a bag of medications, the ones that they're actually taking, because oftentimes, that list gets added to and taken away from. Sometimes we don't know what's what. So a bag with all the medications you're taking is very, very important. And the reason that is because Erleada can increase or decrease the dose of other medications in the system, and other medications can increase or decrease the dose of Erleada. That's typically something we can always manage by adjusting doses of medications, but we only know if we should do that if we have an up-to-date medication list every single time. Okay, how the medication is used. So it's very easy to use. It's 4 tablets that is prescribed once daily. It is needs to be given with some sort of mechanism of decreasing the testosterone. So whether that be androgen deprivation therapy, or maybe you're a patient who has a bilateral orchiectomy, you obviously don't need to be on those hormones also, but something that is keeping your testosterone down. Should be taken at the same time every day, and it should be taken with or without food. It doesn't matter if you take it with or without food. If you miss a dose, that's okay. You don't need to double up on the next dose. You take, the same dose the next day. If you forget and, it's a few hours later or it's later that evening, you can still take the dose the same day. But if you forget the entire day, just wait until the next day and just take your normal dose. You don't need to double up. Okay, and there actually is an alternative for patients who may have a difficult time swallowing the medication. And this is really great. I've actually had 1 or 2 patients who have needed to use it this way. What you do is you take all 4 of the tablets. You don't crush them or break them. You just put all 4 tablets in a container of 4 ounces of applesauce. You mix it and you wait 15 minutes. You mix it again, you wait 15 minutes again. And after that, you swallow the entire mixture. And then you're going to clean out the container with 2 ounces of water, drink that water, and then repeat 2 ounces and drink the 2 ounces of water. The caveat to this is, it needs to be kind of taken within that time frame. You can't prep the mixture in a big, in a big container and just do it a little bit at a time. It really should be given an hour after you kind of start the process. So don't think that you can prep it in advance. So storing Erleada, it needs to be stored at room temperature, so between 68 to 77 degrees Fahrenheit, in its original package. It should be kept out of light and moisture, and there's a little desiccant packet in there that needs to stay in there. What that does is it helps keep away moisture, so don't remove that. And of course, you want to store it in a safe place, specifically away from children, because it could be harmful to children. Of course, it hasn't been studied in children. And staying on therapy is very important. Not to say that, just because you start on it means that you have to stay on it indefinitely, but you should never stop a medication without talking to your healthcare provider first. So if you are experiencing any issues, talk to your provider. If you have questions on how to use it, or if you're having any side effects from the medication, or if you just want to stop the medication in general, it's good to talk to your healthcare provider first. And in my experience, if I have a patient who calls and says, I want to stop my medication, that's something that's getting addressed right away. So it shouldn't be, something that you have to wait 6 weeks for. Again, if somebody calls me and says that they want to stop it, they can typically get in for an appointment in the next day or so, and we can have a discussion about it. And oftentimes, we may choose to reduce the dose of the medication to help with the side effects, or maybe there's something else that, we can do for them to help, reduce the adverse effects that they're experiencing. Because again, this medication really helps with, number one, helping patients live longer and keeping their cancer from spreading. So the key takeaways from this presentation: Erleada was the first FDA-approved prescription medications for men who have non-metastatic castrate-resistant prostate cancer, and it also treats men who have metastatic castrate-sensitive prostate cancer. It can help men live longer. It prolongs the amount of time until prostate cancer progresses, and it helps the hormone treatments like androgen deprivation therapy last longer. The most common side effects are fatigue, joint pain, and rash. Decreased appetite, falls and fractures, weight loss can happen, hypertension, hot flashes, and diarrhea. And once again, most of these are very mild, and the ones that are not mild can typically be treated in some way, like dose reduction or maybe adding on a medication that can help with the side effects. So this is a list of questions that you may ask your provider. Can you explain why my prostate cancer has advanced? Where am I at in this prostate cancer continuum? Do I have metastatic disease? And if I do, is Erleada a medication that's right for me, or do you have another suggestion? What else can we do other than hormone therapy? If you are prescribing Erleada, can it delay the type of prostate cancer that I have from progressing and spreading? Can it help me live longer? And what kind of safety information should I know about it? Here's the things you need to know about me. I have a history of heart disease and diabetes. Is there anything more that I need to know? Do I have a problem with my bones? Are my bones strong enough? Here's what I know about myself. What else can be done to make sure that I'm living longer? I think, so this is a list of advocacy groups, educational information, financial support. I think we've all heard of Zero Cancer, but there are a lot of other foundations on here. If you want to, I'll kind of pause on this screen because I think it's a really great resource for good organizations that can give you great information, and even for foundation assistance and patient assistance if you're trying to get medications covered. These are great foundations, and if you have a healthcare provider that may not be astute in getting these medications covered, these are great places to start, as well as they can reach out to their local representative if they need help as well. And this is the last slide other than the thank you slide. So I'm going to stop here. That way, this is another slide full of really great information and different resources where you can get good information other than blogs that, kind of help you figure out where exactly you're at in the prostate cancer continuum. And it gives really great information from patients who may have localized disease versus patients who have advanced prostate cancer and what appropriate treatment options are within those categories. Um, so that concludes my presentation. I really hope you learned something today. And thank you so much for taking the time to hear what I have to say and be proactive in learning about your prostate cancer, because you are your number one healthcare advocate. So thank you for taking the time to learn.
Great. Thanks, Chelsea. We do have a couple of questions coming in, so we'll just jump right into those. And as a reminder to those listening, if you want to submit your question, we'll be able to spend a few moments with Chelsea and we can answer as many as we can get to. So I'll start with the first one that came in, and it's really just a fairly general question: is Erleada used if surgery or other treatments are not a possibility? So if you could just speak to, maybe the prime candidate for a medication like this, I think that would be really helpful.
Sure. The answer to that question is yes, Erleada is a candidate. Erleada is a potential treatment option for somebody who's not a candidate for a prostatectomy if they fall within those two disease states, which are non-metastatic castrate-resistant prostate cancer, meaning the prostate cancer that's no longer responding to hormone treatments anymore, but their PSA is rising. So if you can visualize that little bubble on the bottom, these are patients who have been on hormone therapy for a while. The hormone therapy, unfortunately, is no longer working, and the PSA is starting to climb. So it's a really great treatment option to keep the prostate cancer from metastasizing and spreading, when if we were to do nothing, it would metastasize and spread. And then the other area where we can use Erleada is for those patients that we had talked about that have what's called metastatic castrate-sensitive prostate cancer. And again, those are the patients who we're meeting who unfortunately are already metastatic at the time that we're meeting them. They've never been treated for prostate cancer before. This is all new to them. So typically at that point, we would put them on hormone therapy, because that's going to drive the testosterone and PSA down. And then adding Erleada on top of it is going to keep that cancer from getting worse, metastasizing further, and those hormones working longer. So those are the two spaces you can use Erleada. So you can actually use it in patients who have had prostatectomy before, and even patients who aren't a candidate for prostatectomy because their prostate cancer has already spread.
Okay. And would you mind doing a quick comparison of Erleada and Zytiga? We've had that question come in as well.
Sure. So Zytiga is also recommended in the metastatic castrate-sensitive prostate cancer space. And again, is the patients who have never been treated with hormone treatment before. And it's actually also indicated for patients who have metastatic castrate-resistant prostate cancer. So once the cancer has metastasized past the space where Erleada is indicated, that is a really great space for Erleada to be, for Zytiga to be used. It acts a little bit differently. It's the way that it works is a little bit different. It works on the production of testosterone in the adrenal glands. As I had mentioned in my discussion, there is some degree of testosterone that's produced in the adrenal gland. So it does work a little bit differently. And as a result, you have to be on steroids while you're using it, because it can affect some of the hormones also produced by the adrenal glands. So it has to be monitored a little bit more closely. I have a lot of patients on Zytiga. I think it's a great medication. I just have to see them more regularly. We check, electrolytes on a regular basis. They are on hormone treatments. In the metastatic castrate-sensitive space, either one can be used and both have great data, but it can also be used in a space where Erleada cannot, which is patients who have progressed past that.
Sure. We have a question that's a little bit specific, so do your best because we're not going to offer treatment advice necessarily, but sure. For men who were on Zytiga and maybe Firmagon, and I'm using a very specific example here, so I guess
Sure,
I shouldn't say it maybe, but Zytiga and Firmagon that had the PSA began to rise again. So this person then switched to Zytiga. Would Erleada be another option for a patient like this who has a rising PSA but has already tried both Zytiga and Xtandi?
So no. That is an example of metastatic castrate-resistant prostate cancer. I would assume, because if they are on Zytiga, Zytiga is really only indicated in those metastatic spaces, meaning when the cancer has already metastasized. And if they're progressing through the Zytiga, they really need to be on a different treatment, and Erleada is not recommended in that metastatic castrate-resistant prostate cancer space, which is that final bubble in my presentation. So once their cancer has already metastasized, once it's not responding to hormone treatments anymore, Erleada is not indicated in that space. The great news is there's a lot of other treatment options there. You have Xtandi, there's Provenge, there's a medication called Xofigo, which is a radiotherapy that helps with bone metastasis. There's also chemotherapy. So there are a lot of different options in that space, but Erleada is not one of them.
Great, thank you. And we have another question, really just about the side effects of bones and muscles weakening and increasing the risk for falls and fractures.
Sure.
So any additional comments that you can have would be really helpful, especially for patients that have had salvage radiation therapy.
Okay. So, salvage radiation therapy, I think is probably not applicable to, obviously radiation therapy can cause weakness and fatigue, but I think it's probably unrelated to this as it pertains to Erleada. So with Erleada, with hormone therapy in general, I'm going to address bones first, and then I'll address fatigue and fractures. So with the bones, anytime a patient is on androgen deprivation therapy or the hormone therapy that brings the testosterone down, the biggest thing that we worry about if they've been on it for 2 years or longer is it decreases bone density. So those bones get weaker and patients are at an increased risk for fracturing if they fall. It's very, very important to make sure that patients who are on hormone therapy alone, not talking about anything else, are having their bones managed appropriately. So in my clinic, we have DEXA scans every 2 years, and there are medications that patients can go on called, bone sparing agents. Examples of that are Prolia, Xgeva, Zometa, and all these medications help to strengthen the bones. So that is outside of any sort of additional therapies that we're talking about. That's just androgen deprivation therapy alone. Also, androgen deprivation therapy can increase the risk of fatigue and falls, right? It causes weakness. That's a common adverse effect, makes people tired. Now, adding Erleada on top of that kind of makes both of those things, potentially worse, okay? So the best thing that you can do is make sure that your provider is, number one, taking care of your bones and making sure that you're getting these DEXA scans regularly. And if you're a candidate for bone sparing agents, maybe you're not, there are some patients who aren't candidates for it, but if you are a candidate for it, making sure that you're on some of these treatments. And then if you already are weak, have a conversation with your doctor about whether or not you're too weak for the medication, or maybe you need to be on a half dose of the medication, or maybe you just need to take some extra precautions. I have patients in my practice who, in Florida, I'm from Florida, everybody loves those like slip-on shoes. They wear sandals like all winter long, and those are no-nos in my practice. You need like good shoes that strap onto your feet. Sometimes it's just a matter of having a good conversation on how you can do these things. Getting, the bars, like the bars in the bathroom, transferring in the bathroom is typically the biggest fall risk. So, making sure that your bathroom is set up appropriately so that way, you have something to grab onto if you're starting to feel weak. If you're a family member and you're nervous that, your family member might feel frail, What can you do around your home? Can you pick up rugs or that type of thing to mitigate the fall risk? So, is it a risk? Certainly, but are there things that you can do to mitigate that risk? Absolutely.
Yeah, that makes a lot of sense. And I think you also it kind of brings up a good point of making sure you're having open discussions with your care team and bringing to their attention, obviously not when results come back from like a DEXA scan, but when
Sure.
you're noticing side effects, reporting those side effects to your treatment team can really make you stay on treatment longer and allow you to stay on treatment longer. So because you can manage those together. So I think that's a great point.
Sure, absolutely.
Thank you. So we have another question. Is OsteoMD adequate to treat osteoporosis caused by ADT?
Okay. I'm not familiar with that medication, so I don't want to comment on it.
Sure.
I don't know if that's a supplement or what that is, but what I can say that we use in our practice most commonly is Prolia, which is an injection that's given once every 6 months for patients who don't have metastatic disease. And then patients who have cancer that has metastasized to their bones, they need a little extra help. So they're given Exgeva, which is a monthly injection. And of course, every patient, regardless of whether or not they're on bone sparing agents, are on calcium and vitamin D. So if that supplement is a calcium and vitamin D, some sort of calcium and vitamin D supplement, then I think that it's good that they're on it, but they may discuss other, more aggressive options for bone health if they're on hormone therapy for more than 2 years.
Okay. Great, thank you. We have another question. This is coming from a man who is not newly diagnosed, has had more than 2 rounds of radiation, a prostatectomy, and has been on ADT therapy for about 7 years. Luckily, the cancer is still castration sensitive, but this patient is currently on Eligard and wonders if Erleada might still be effective for this type of case.
Okay. So if he has castrate sensitive disease and he's non-metastatic, then fortunately he's not at a place where he needs Erleada, which is good news. Androgen deprivation therapy by itself is an appropriate treatment option. There are studies all the time ongoing, and I don't know of one off the top of my head right now, but if there is an additional therapy that he's wanting to consider, it might be worth talking to his healthcare provider to see if there's any studies going on in the non-metastatic castrate sensitive space. Once his PSA starts rising, I hope it never does, but if his PSA starts rising, that puts him in the non-metastatic castrate-resistant prostate cancer space, at which point he would be a candidate for Erleada.
Okay, actually, this person was just able to comment again that this person is metastatic.
So metastatic, and his PSA is staying low?
Yes, I believe that's correct.
Okay, so that would be a very unique case, I would say. Unless he was metastatic a long time ago, rarely do we see people who are metastatic who have very low PSAs for a long time. If somebody I actually have a couple patients like that, they're metastatic and they have very low PSAs, but they present much differently. Typically, those are patients who are very progressive, very, very aggressive, and they grow very fast. So that doesn't seem to fit this clinical scenario either. So I would say I feel like I can't appropriately comment on that particular situation.
Sure, absolutely. We have another question just really about how to take the pills and when to take the pills. This one is specific to Zytiga, if you're able to comment. So this person is wondering what would be a preferred method. Would it be 4 pills on an empty stomach or 1 pill with a meal? A pill with a meal, excuse me. And is there a preference?
There's not a preference, and either one is appropriate, and we use both in our practice. Typically because the medication was studied on 4 pills with an empty stomach, unless there's a reason to take 1 pill with a meal, we typically just stick to the way that the medication is recommended. 4 pills on an empty stomach with prednisone twice a day. But Again, there are always certain circumstances, maybe there's an issue with the patient being able to swallow pills, or, maybe there's a problem and they're running out of their prescription, or maybe they don't tolerate 4 pills well. I mean, there's all different reasons to kind of change the plan, which we do. We pivot all the time, right? So either one is appropriate. It's just important to talk to your healthcare provider about what they're recommending and why, because either one works perfectly fine. It's just what works best for you.
Great. Yeah, absolutely. No blanket treatment plan here.
Yeah, exactly. We like to tailor care.
Right, exactly. So we have a question about just general ablation, and if you can chime in on that, speak to that. So we know that there there's cold therapy, heat, laser, chemical types of ablation, and when one might be considered over another for treating prostate cancer. I know that's sort of a loaded question. It's a lot.
Yeah.
But we did have that question come in.
Yeah, I probably will not comment on that, mostly because my area of expertise is advanced prostate cancer. I do prostate biopsies and those types of things, but the ablative therapies and everything is not something that we regularly use in our practice. So I don't want to speak out of turn and give bad advice.
Oh, no problem. And there are some sessions that will cover those topics a little bit more in depth later in our next couple of days. So we have another question. Would it be okay to take Erleada along with the new oral drug, Relogolix, or do you think that's too much oral medication?
Relogolix. Orgovix?
Yeah, Orgovix.
Orgovix. No, that's actually a perfect. So Orgovix, and I had actually, I think, mentioned it earlier in the conversation in my presentation. Orgovix is a brand new medication that has been FDA approved. It's oral. It's basically oral androgen deprivation therapy. So instead of getting a monthly injection of Eligard or Lupron or Firmagon, you can take a daily pill. So it's used interchangeably when I talk about androgen deprivation therapy. Orgovix is used interchangeably with androgen deprivation therapy or Lupron. So it's not too much medication. What I would kind of stress is obviously Erleada is only indicated in these 2 spaces, and Orgovix is, FDA approved anytime androgen deprivation therapy is indicated. So it really kind of depends on that particular person's prostate cancer and where they're at in the prostate cancer continuum. But if they have either non-metastatic castrate-resistant prostate cancer or metastatic castrate-sensitive prostate cancer, then Orgovix and Erleada is completely appropriate.
What about if a PSA rises after Lupron paired with Zytiga? Is that really just considered a failure of that combination therapy?
That's a really great question. So anytime you're on any therapy, whether it be Zytiga, Erleada, Xtandi, chemotherapy, any sort of therapy that you're on, PSA failure, meaning the PSA rising, is technically not an indication to pivot and move to something else. What we use for a failure of a medication is actually progression on scans, meaning if you have a CAT scan or a CAT scan, bone scan, PET scan, anything like that that shows progression, then you have failed. And at that point, it is time to kind of pivot and come up with a new plan.
Okay. What about for a newly diagnosed patients with metastases, but only to the lymph nodes, not elsewhere throughout the body? Would Erleada be would Erleada be a treatment option for a patient who has metastases to the lymph nodes?
That's a really great question. So it depends on the lymph node and it depends where. Okay. So if the lymph node is below the level of the aortic bifurcation, meaning it's down near the prostate, and say it's just one small lymph node, that is technically only considered nodal disease and it's not metastatic. Okay. So by definition, they do not have metastatic prostate cancer. Does that make sense?
Yeah.
But that is really kind of, that's definition, but that is really kind of provider specific. So, you might go to one person who said, you might go to one doctor and they say they have a node. I think that's appropriate. And they might say that Erleada is appropriate. Somebody else might look at that scan and say, that's just considered nodal disease. That's not metastasis, and I don't think they're a candidate. So a lot of this is some art, some science. But I would say if that were my patient, it would just be considered nodal disease. And but if they have nodes outside of that area, maybe they have a whole bunch of lymph nodes, those lymph nodes are up higher, absolutely, that's metastatic disease and they're a candidate for Erleada.
Right. And I love that comment, half art, half science. I think that's just, it's such a great description for treating cancer patients. And we talked about there's no blanket treatment plan. And I think it really speaks to the importance of seeing someone who has experience and a good amount of experience treating prostate cancer, because they can incorporate that half art, half science aspect into it.
Yeah, it's kind of wild. I mean, in the 7 years that I've been doing this, I can't believe how much has changed. I mean, and I look at breast cancer. I mean, I'm not an oncology specialist. I don't know hardly anything about breast cancer, but I mean, I hear about breast cancer and I see how specialized everything is and how patient specific everything is, and all of the different testing and treatment options, and ways that we can specialize prostate cancer to individual patients. And we're getting there. We're getting closer. Unfortunately, we're just a little bit behind in prostate cancer, but we're growing at the speed breast cancer was just a few years ago. So it's a really exciting time to be doing this.
Yeah, absolutely. And really exciting to see the progress in other cancers, because we know that we will learn something in prostate cancer from those other tumor types.
Absolutely.
Humans. Well, with that, thank you so much. Thanks for letting us grill you with all of the questions that came in. We're thrilled that we had so many listeners. So I'm so excited, really speaks to the excitement around this topic around Erleada. I want to say thanks again, Chelsie. Thanks to you for taking the time. A huge thanks to our sponsor, Janssen, for introducing us and making this valuable content available to all of our listeners across the United States and really the world. So thanks again. Thanks for being a part of our 2021 Prostate Cancer Summit. Don't go anywhere. We have a few more hours of content for you coming your way. Coming up next is actually a session with Ali Sachs, who will be discussing mental health. Again, we talked about how important mental health is, especially in a pandemic, but also with a prostate cancer diagnosis. So be sure to stay tuned. And for more information on this topic, on other topics, please visit our website at zerocancer.org. So thanks so much, everyone. And we look forward to seeing you back in the app.